we have a final word from Mark Sneddon, but I might get our panellists settled while we hear from Peter. And perhaps we can get our panellists a glass of water. I'm not sure if there's anyone at the back who can make that happen. Thank you. So, sorry, without further ado, Mark Sneddon.
Good evening, ladies and gentlemen. Thank you for inviting me along. I am a rose among thorns, or a thorn among roses. I'm the only lawyer speaking tonight in a bevy of medical experts. I have practiced law for nearly 30 years, been an associate professor of law at the University of Melbourne in a large law firm, Clayton Utz. I was also Crown Counsel to the State Attorney General and Premier's Office under the Napthine government, and then under the Andrews government under Martin Pakula. And since then I run a think tank which looks at these sorts of issues called the Institute for Civil Society, and I run my own legal practice. So, and in fact, last week I was spending about 6 hours lobbying both the New South Wales government and the New South Wales opposition why not to introduce a change of suppression practices legislation in New South Wales. Okay, so I just want to canvass quickly some legal issues before we hear from some of the real stars here who have personal and no doubt poignant stories to tell. So let me start with the Keira Bell case. Keira Bell was a 16-year-old natal girl who's diagnosed with gender dysphoria at the Tavistock Gender Clinic in London. She was diagnosed, I think, initially at 15, and she was put on puberty blockers and hormones at about 15. She later had a double mastectomy. In her early 20s, she greatly regretted what she had gone through, even though she had sought all of those things, and she sought to detransition her body back to female appearance. She sued the Tavistock, not in negligence, but claiming that it had acted unlawfully in prescribing puberty blockers to her and cross-sex hormones and commending her for cross-sex hormones while under 18, on the basis that people under 18 could not give informed consent. So she wasn't actually saying that she couldn't have given informed consent. She was saying you are acting illegally in your procedures by giving these sorts of treatment to people who are not capable of giving what the law calls Gillick consent. Gillick consent is that you must be able to understand the nature of what is being proposed, the consequences of the treatment, and you must be able to understand and make a sound decision on your own interests as to whether or not to proceed with it. That's the normal test for medical consent. She won at first instance in the divisional court of 3 judges, which described puberty blockers as an experimental treatment and generally beyond the capacity of people under 16 to consent to. That was reversed in the Court of Appeal because they said, well, it's really a matter for the medical practitioners to judge Gillick consent rather than making blanket rules as to whether someone under 16 or over 16 can. So it was, remember, this is about the general rules, not about Keira Bell in particular. And the Court of Appeal said, we can't make a bright line rule that nobody under 16 can ever consent to this, but they gave plenty of hints that you'd need to have a very good confidence in your assessment that someone under 16 could do so. Well, following public concern after the Keira Bell case, they set up the Cass Review, which you already heard a number of speakers refer to. The Cass Review said the most difficult question was about puberty blockers, whether they were provided valuable time as emergency treatment to interrupt puberty or whether they were effectively locked in children. And data from both the Netherlands and from GIDS Tavistock showed that almost all children, 96.5 or 98%, who were put on puberty blockers went on to cross-sex hormones and then maybe onto top or bottom surgery. So they were not a pause in practice for people at all. The Cass Review also said there are unknown impacts of PBs on development, maturation and cognition, but you've heard that from the experts already. So in June of this year, NHS said there is not enough evidence to support the safety or clinical effectiveness of puberty blockers to make the treatment routinely available. So they will be limited to supervised clinical trial studies. Question for you and for me and for everyone in this room is, why isn't that the case in Australia? Okay. Let me then just move on quickly to a couple of issues which my friend and colleague Patrick Parkinson raised also. What about lawsuits about medical gender transition? Well, a lawsuit in negligence, and like him, I'm not I'm grateful for the medical practitioners who have the courage to stand up tonight and swim against the stream. Okay. And we need more people exercising moral courage in this day and age in all fields of life. So well done them. If you were going to bring a lawsuit of negligence, you could frame it in a number of ways. You could say there was an inadequate investigation of the patient's issues. There was just a ideological predisposition to a particular diagnosis. Bang, you're on the conveyor belt. You could say you ignored other pathologies. You didn't investigate this particular individual properly. That was negligent. You could say that you prescribed inadequately researched treatments like puberty blockers, the long-term effects of which were not known, etc. And then there are the issues about patient consent. Could this particular patient meet the test of Gillick competence and understand and give informed consent to what they were doing? So we have in the UK, for example, a number of cases along that line. Richie Heron had a vaginoplasty at 31, and he's suing the NHS for medical negligence. And there are plaintiffs' lawyers who are supposedly preparing a 1,000 adolescent patient class action against the NHS GIDS. Nothing surfaced in the public record about that yet. There are, as you would expect, multiple lawsuits in the United States on this area. In Australia, there are two that I know of. One is a case called Langadinos and Tui, which has been in the press. And May 2010, a Sydney woman, Jay Langadinos, saw psychiatrist Dr. Patrick Tui when she was 19, living at home, identifying as a male. She sought and he prescribed sex hormones. She later sought permission or a certification that she was competent to undergo bilateral mastectomy and a hysterectomy, and he said there was no psychiatric contraindication for her to do so. Jay has regretted and detransitioned and is now suing Tui for professional negligence because she said she had a range of other psychiatric disorders at the time which would have made it impossible for her to give informed consent in those cases. Now, I'm not making any comment about the rights and wrongs of that particular case, and I note that Jay was an adult at all times when she was requesting advice and procedures from Dr. Tui. But there's a significant issue in here about the professional responsibility of these individuals and the surgeons. I mean, we've just heard from one plastic surgeon who said, I would not do that. But clearly there are other plastic surgeons who say someone's ticked it off somewhere, so I'll execute the surgery. So the insurer MDA National has said it will also no longer insure private doctors such as general practitioners from legal claims arising from the assessment of patients under 18 as suitable for gender transition treatments. That's one of the four main private doctor insurers. So that would be good if that extended on further, because that will be a thing that will stop it very quickly. But that won't stop it in government hospitals because they're not insured by the private insurance. Second area to look at is family law, and I think Patrick Parkinson adverted briefly to this. In a couple of cases in the 2000s, the family court determined it would only get involved in cases of giving permission or not giving permission for gender transition where either one of the parents or the clinician disagreed with the proposed gender treatment. That usually turns out to be one of the parents. And that was because the full family court accepted expert evidence from the medicos in that case that the affirmation approach was sound practice and treatment by puberty blockers had no harmful long-term effects and was reversible. That was thought to be the best evidence at the time. There is an excellent paper by a barrister at the Victorian Bar called Bell Lane, B-E-L-L-E, I see if you're nodding, L-A-N-E, which goes through this in great detail and says that decision of the full court of the family court was made on the basis of evidence which has now changed. We now know that some of this, we know the effects of puberty blockers, as revealed in the Cass review, are quite different to what was the basis for that decision, and that decision ought to be reviewed. There is a recent case in November 22 in the family court, no names because you can't publish anything like that in the family court, but a Melbourne lawyer, Bill Cordos, acted in that case, and where the parents, the reason it got to the family court is the parents were disagreeing about what was the appropriate treatment for the child, and I can't remember which parent it was, the parent who was against the gender-affirming treatment was able to put the relevant doctors and clinicians from the Royal Children's Hospital Gender Service on the stand and ask them some tough questions about why they were doing it and what their evidence basis was. And the net result of that case was that the other parent became sufficiently convinced it was not a good idea, that the other parent withdrew their objection and the child did not go through gender-affirming procedure. Now, there was not a decision of the judge in that case because it settled, because the parents came to an agreement. But it's that sort of litigation we're not. But what we most need, I think, is some sort of sensible independent inquiry into all of this, because we seem to be continuing down a path where I understand there's great division around the world, but quite a few countries are reversing their position on where they were, and we need to stop and have a look at it. The final point I wanted to discuss is this ideological legislation which makes the whole problem worse, and that is the change of suppression practices legislation. We have that law in Australia in 3 jurisdictions, in Queensland, although I was going to say it's not too bad, but it is bad. It's just as bad for my medical colleagues because it applies only to health service providers and prevents health service providers from engaging in change or suppression practices. But in Victoria and the ACT, it applies to everybody. It applies to parents and friends and family and counsellors, and if you're religious, your priest or your imam. Nobody in Victoria can engage in practice or conduct directed to a person on the basis of the person's sexual orientation or gender identity for the purpose of changing or suppressing your sexual orientation or gender identity. Gender identity is unhelpfully defined as your gender-related identity. And you can try and work that out in more detail, and that would be a discussion for another time. It clearly covers psychiatry, psychology, counselling and prayer. And then there are some defences or exceptions. So there is a defence or an exception for a health service provider who is convinced that in their reasonable professional judgment, the medical course they are going to undertake is necessary for the patient's welfare. Necessary for the patient's welfare. There's also another exception that if you're assisting someone to transition or you're assisting someone to consider transitioning, fine, all good. So the real problem with this legislation is the thumb on the scales. And if I'm advising a medical practitioner and I say, well, you've got all your normal duties of care, your clinical requirements and so on, and in addition, the Change of Suppression Practices Act says to you, if you want to go down the affirmation path, no problem. Knock yourself out. If you don't, if you want to say to someone, maybe we should do the holistic assessment and pause puberty blockers and not do that sort of thing, then it's entirely possible that the Equal Opportunity Human Rights Commission might come and talk to you and say, well, that's a suppression practice. And then you'll have to say, oh, but in my reasonable professional judgment, this is necessary for me to treat the patient. So you have to mount a defence in Victoria if you're a medical practitioner trying to do that, whereas if you're going the other way, no problem at all. Let me just finish by telling you what the Equal Opportunity Human Rights Commission has said about this. It has guidance. I think at some points, I'll just express myself carefully, the guidance put out by the Human Rights and Equal Opportunity Commission is it goes a little bit beyond the legislation. That is, it may not be entirely faithful to what was said by the Attorney General in parliamentary debates in answer to questions by Mr. Limbrick and others, and it may not entirely square with it. So just treat with some caution. But this is the question on the question answer on their website. Does the Change and Suppression Act capture wait-and-see approaches to gender transition? Well, answer. Change or suppression practices includes those that seek to suppress a child's sexual orientation or gender identity. Suppression may include, for example, trying to stifle or stop your child's need to be a different gender than they were assigned at birth. Whether the definition captures wait-and-see approaches depends on the circumstances that people are in. A parent or carer may be engaging in a change or suppression practice if they deliberately cause long delays, especially as some treatments are time critical. An example is waiting until the child is 18 to permit that child access to professional health advice in the hope the delay will stop the child's gender identity or sexual orientation. Now, I don't think any parent is going to stop someone seeing a doctor until 18. What they're really talking about here is puberty blockers without actually saying it. Right. I think this is a shameful business that we have this law in Victoria and that the Human Rights Commission and that the Human Rights Commission is advising people in this sort of chilling, intimidatory fashion. I think it's really bad, and that's why I'm spending quite a bit of time with New South Wales to try to avoid them going down the same path. I do not want to frighten parents in the room. I think you still need to do the right thing by your child, and the best thing you can do is seek out a sensible doctor who will, or psychiatrist or psychologist, who you might have to go to Queensland. No, sorry, I'm sure they're in Victoria, but they're probably fearful. Exactly. But seek out a sensible doctor, because if you have someone who is sensible and brave, they can use that defence in the act to say, in my reasonable professional judgment, this is the necessary course for this patient. And if a parent is following what a doctor is saying, and the doctor's prepared to say that, I cannot see the Human Rights Commission trying to come after that parent. That seems to me to be your best course at the moment.